It's a real privilege to be able to talk about this topic and give this state-of-the-art lecture. Here are my declarations of interest. So if we think about SGLT2 inhibitors, in some ways they're really a very simple drug for diabetes, and this gives a bit of the history of the class. And so the, kind of, if you will, the original compound, fluorescein, was isolated from the bark of the apple tree in the mid-1800s. And several decades later, it was noticed that high doses of fluorescein would increase urinary glucose excretion. And then it was appreciated that then now, about 70 years later, that the mechanism by which it did that was to inhibit renal glucose reabsorption. And so fluorescein had been used in a variety of animal experimental studies, but it wasn't really until the late 1990s that the notion came that you could administer this drug, in this case to mice, to block the increase in blood glucose that would happen after ingestion of a glucose solution. And so the notion of now using this drug to actually potentially treat hyperglycemia started to come into focus. And so then a few years after that, fluorescein analogs were developed. The first SGLT2 inhibitor was tested in humans, I think in 2003. I think that was dapagliflozin, but there were a variety of first-in-man studies happening at that time. And I believe, again, the first to be approved for use in humans was dapagliflozin by the EMA in 2012. And so in terms of a strict diabetes point of view, this class basically reduces levels of hemoglobin A1C by about 0.6%, depending on what the starting glucose levels were in the individual, which is fine. But as we've come to know, and Mikhail very nicely covered, this class does much, much more than that. The reason, of course, we know that is because of the mandate first put forward by the FDA now more than a decade ago, saying, as we study drugs for diabetes, certainly while A1C remains an acceptable primary efficacy endpoint for treating hyperglycemia, overall now there needs to be data for cardiovascular risk. And so that led to the requirement to show cardiovascular safety, really based out of concerns for TZDs, potentially increasing, or at least one TZD, rosiglitazone, for potentially increasing the risk for MI. So there was this, if you will, obligation to gain more data for cardiovascular outcomes, not just rely on a surrogate, which is hemoglobin A1C. And so that led to a series of cardiovascular outcomes trials designed for the three members of this class that were first in development there, so empagliflozin, canagliflozin, and dapagliflozin, so the EMPA-REG outcome, CANVAS program, and DECLARE TIMI 58, which Steve was the co-PI for, to then look both for really initially primarily cardiovascular safety, but given that these were large trials, and you can see the number of participants range from 7,000 up to 17,000 in DECLARE TIMI 58, but it also created the opportunity to look for efficacy in terms of cardiovascular outcomes. You can see the median follow-up is several years in all of these trials, up to 4.2 years in DECLARE TIMI 58, and the typical demographics that we'd expect for patients with diabetes. And so here was the result for the first of these trials to report out EMPA-REG outcome. And here you can see not only did they show that it was safe from the perspective of MACE, so the composite of CV death, MI, or stroke, but that also it actually reduced the incidence of MACE, here with a hazard ratio of 0.86, so a 14% reduction, with an upper bound of the confidence interval of 0.99, so just making statistical significance at a p-value of 0.04. And this really was a landmark moment for the development of drugs for diabetes. No longer were we now just satisfied with A1C reductions, This trial then showed that you could actually reduce cardiovascular outcomes. So that was really an amazing watershed moment for the treatment of patients with diabetes. Now, the key efficacy outcome was MACE because these trials started as safety trials to make sure there was no excess of MACE. But in fact, in EMPA-REG outcomes, they did explore looking at CV death or hospitalization for heart failure. And here, in contrast to the MACE effect, which was certainly welcome to have a 14% reduction, but here an even more robust treatment effect, a 34% reduction in the composite of CV death or hospitalization for heart failure. So very powerful data. After that, then the Canvas program reported out, and you can see here very similar results to what was seen for EMPA-REG outcomes. Hazard ratio also of 0.86. Again, the confidence interval almost touching 1, but a little bit below, so a p-value of just under 0.05, 0.02. So again, very nice to see, in fact, a somewhat of a reduction in the risk of MACE. And just like what was seen in EMPA-REG outcomes, an even more robust effect on CV death or hospitalization for heart failure, in this case a 22% reduction. And then at AHA in 2018, Dr. Wiviet presented the results for DECLARE-TIMI 58. And so we actually seeing the landscape evolve, being the third of the 3 big outcomes trials being done, then actually elevated CV death and hospitalization for heart failure as one of the dual primary endpoints, so elevating it up next to MACE. And so we saw a significant reduction in CV death and hospitalization for heart failure, 17% reduction. And for MACE, the hazard ratio was 0.93. And in this case, the upper bound of the confidence interval was 1.03, so just missing statistical significance. But the pattern of the data was extremely similar. In addition to the signals for MACE and then for CV death and hospitalization for heart failure, what also emerged were powerful data in terms of preventing progression of renal disease. And this was seen in all of the trials. I'll highlight the data here from DECLARE-TIMI 58, where for a cardiorenal outcome that included renal outcomes and CV death, and probably more relevantly for this discussion, the renal-specific outcome of decreasing the GFR by at least 40%, end-stage renal disease or renal death, almost halving the risk for that, a 47% risk reduction. So now really very powerful data that this class not only is safe in terms of MACE, reduces the risk of MACE in fact, and then more robustly reduces the risk of hospitalization for heart failure and progression of renal disease. Now, these trials, while I showed them as similar in some ways, it's also important to note there were differences between them. And here I've added some additional features for the trial. And so the proportion of patients who had established atherosclerotic cardiovascular disease varied from it being all of the patients in EMPA-REG outcomes to the majority in Canvas to a minority in DECLARE, where we wanted to deliberately have the trial reflect sort of the broader world of patients with diabetes. Second point is the history of heart failure. These weren't dedicated heart failure trials. The prevalence of heart failure in these populations was on the order of 10 to 15%, so a minority of all the patients that we studied. And then the renal function differed in these trials based in part on some of the inclusion and exclusion criteria for them. But here, noting the fraction or the proportion with the GFR less than 60 was about a quarter in EMPA-REG outcomes in Canvas, and only a small number in DECLARE, and that'll be important. I'll get back to that in a minute. So as we think about these trials, then while there are some similarities, there are also some important differences. And Dr. Thomas Zelnicker, who you'll hear from in a few minutes in this session, is one of our senior cardiology fellows, did this very nice meta-analysis, putting these 3 trials together and looking at the patients stratified by whether they had a known history of atherosclerotic cardiovascular disease, and that's the forest plot at the top of this slide, versus patients just with multiple risk factors, and that's the bottom part. And you can see there that there appeared to be a difference, at least in terms of MACE, that the effect was more robust in patients who had known atherosclerosis versus patients who just had multiple risk factors. I'll say with the caveat being that this is what we saw over the time frame studied. And it doesn't mean that with longer follow-up you might not see the same benefit in this lower risk subgroup shown at the bottom. But in fact, when you split the patients and do a like-to-like comparison, in fact, the results for the trials are quite similar, with about a 14% reduction in MACE for patients with established atherosclerotic cardiovascular disease. And in fact, then when Dr. Zellniker looked at the breakdown of the effect on MACE, really the most robust effects were on CV death and MI, and really no effect on stroke. The other part of this really comprehensive meta-analysis that he did was then looking at the impact on CV death and hospitalization for heart failure in patients stratified by a history of heart failure. Those with a history are at the top of this graph, those without at the bottom. And you can see that the relative risk reductions don't statistically significantly differ. So 29% on top and 21% for those without, both significant, and maybe a trend towards a slightly greater effect in those with a history of heart failure, but clearly good for patients with and without a history of heart failure. And so that was also a fascinating development. Here was a drug that reduced, if you will, incident hospitalization for heart failure, something in the cardiovascular community we haven't really thought about as much. We think about patients with heart failure and preventing recurrent hospitalizations. We don't think as much about preventing that first hospitalization, preventing them from going down that road. So very compelling data here. Another one of our fellows, Eri Kato from Japan, did this analysis. Again, because we were the third of the trials, we had the benefit in DECLARE of being able to rigorously gather data on the history of heart failure in our patients, including being able to ask the sites to categorize patients, use the information available in terms of whether the patients had evidence for reduced ejection fraction or not. And what I show here are then 3 cumulative incidence curves that Eri presented and now published in Circulation for patients. In bottom in green are those without any history of heart failure. In blue were patients with a history of heart failure but without a reduced ejection fraction. And in red were those with a reduced ejection fraction. See, the numbers are small. These weren't dedicated heart failure trials, but you can see overall that there was a greater relative risk reduction in those patients with HFrEF. And you can see not only were they at higher absolute risk, but a bigger relative risk reduction. Interestingly, if you look for hospitalization for heart failure, really the groups are more similar. So there's the same 20 to 30% reduction in hospitalization for heart failure, whether the patient has a history of heart failure or not. Really where the divergence was in the effect for mortality. Here I show all-cause mortality, but really those HFrEF patients appeared to enjoy a particularly large benefit. So with these data then, and Mikhail alluded to this in his opening comments, it started with, and I have as the rows here, the 3 currently available SGLT2 inhibitors, or at least the ones with large outcomes trials reported. The original trials were in patients with atherosclerosis or risk factors for atherosclerosis, and I've shown these data here. But now the field has really expanded. Now with more trials now looking at heart failure, and looking at CKD, and the individual trials are shown here. And I'll share some of the data that's been reported, or at least press releases, for 2, one trial with CKD and one trial for heart failure. This is Credence. This is the trial in patients with CKD here. And here the outcome is end-stage kidney disease, doubling of serum creatinine, or renal or CV death, and a highly statistically significant 30% reduction. So building on the data we saw in DECLARE-TIMI 58 and other trials where there was a reduction in renal outcomes, but by and large in a patient population that had few people with moderate or severe CKD to start with. Here, looking at a sicker population in terms of renal disease, seeing a very big effect here in those patients, so really extending that finding. And in fact, if you look for the individual components, even for the harder components for needing dialysis or renal death, which are rare, but they all line up perfectly well. So it's really very encouraging data for this class. In addition, for CV death and hospitalization for heart failure, 31% reduction in this population that has CKD, and for MACE, a 20% reduction. And Dr. Zellniker will show some data that the amount of baseline CKD appears to give insight in terms of the benefit of SGLT2 inhibitors on the reduction for MACE. In the last few minutes, then, I'll just say that for DAPA heart failure, this is a trial that Mikkel and I both had the privilege of being on the executive committee for. So this was now a dedicated trial of patients with heart failure with reduced ejection fraction. The inclusion criteria are shown here. The patient characteristics have been published already, and sort of a typical HFrEF population, except to note how well they were treated. And if you look in terms of the use of ACE inhibitors, ARBs or ARNIs, beta blockers, MRAs, all very, very high use, really outstandingly well-treated patients. And now for the primary results of that trial. No, I'm kidding, I'm not going to show that. I will, however, show the press release that came out now a little more than a week ago. And I think as many people here know, the positive results from this trial, statistically significant and clinically meaningful reduction of CV death or worsening heart failure. I would encourage everyone here to come to the hotline session tomorrow, and DAPA heart failure will be presented by John McMurray at 3:38 p.m. in the main auditorium. So let me conclude here. The risk of MACE, as we've shown, has been decreased by SGLT2 inhibitors, really a robust decrease in the risk of hospitalization for heart failure, robustly decreases the risk of progression of kidney disease, and stay tuned for more trials. And I will have a new take on an old adage, which is an apple a day, or more precisely an analog of a chemical in the bark of an apple tree, keeps heart failure, kidney disease, and MIs away, which I think is really a great move forward for the field. My last slide is just to go back to that FDA guidance to note that without these large cardiovascular outcomes trials, we would never have known about this broad and clinically substantial benefits. So thank goodness these trials are being done. It really has opened up the door for wonderful treatments for our patients.